I'll go ahead and introduce our second speaker, Jane Ching. After her Doctor of Pharmacy degree, Jane did a 2-year transplant pharmacy residency at Methodist Hospital, Texas. She's our transplant pharmacist, as I said, and program director for pharmacy training program at State University of New York, Downstate Medical Center. Jane is very outstanding and will be speaking to us on commonly used transplant medications, indications, drug interactions, and contraindicated medications. We look forward to hearing from you, Jane.
Thank you, Dr. Naji, for the introduction. And prior to starting, I have no conflicts of interest or financial disclosures. I've listed some learning objectives for your reference, but in general today, we will be discussing common post-transplant medications, why patients need to take them, common side effects and how to manage these side effects, as well as review some over-the-counter medications that are safe for kidney transplant recipients. The pharmacologic considerations for patients begin even before the transplant process. So prior to transplant, every patient undergoes pharmacologic evaluation, where we look at their medication list to determine whether there are any barriers or interaction to post-transplant medications. Some examples that we evaluate are looking for anticoagulation because they will be at a higher risk for bleed. Drug interactions, such as with certain HIV medications. So in this case, we will try to work with the patient's provider ahead of time to switch their regimen. Medications related to mental health. So this is where we will work closely with social worker to ensure that the patient is stable on their current regimen. And also medications for chronic pain, because this will help us manage patients' pain post-operatively. If they have any medication allergies, any hormonal contraception and replacement therapy, current use of immunosuppressants, because this will put the patients at increased risk of infections, issues with drug absorptions, any illicit substance use or abuse, as well as use of herbal supplements or nutraceuticals. It is during this time as well that we begin to counsel the patients and provide preliminary education on what to expect after transplant in terms of medications so that they are not caught off guard or surprised by what they need to take after. What are our goals for using immunosuppression? The main goals are to prevent acute and chronic rejection. Rejection can happen at any time after transplant. So during the hyperacute stage, it can happen within minutes or hours post-transplant. This is usually caused by preformed antibodies against the donor. This can lead to irreversible damage, leading to graft loss. However, the good news is hyperacute rejection is rarely seen in current practice due to IV immunosuppression that is given intraoperatively. So our main concerns are going to be with acute and chronic rejection. Acute rejection can happen within days or weeks or months after transplant. There is T cells and B cell players that can increase the risk of these rejection episodes. Reversible damage is managed if we catch and treat early on during the rejection phase. And we do confirm the diagnosis through biopsy. Chronic rejection may take months to years to occur, and this is more of a complex pathophysiology. And in the case of chronic rejection, more often than not, this leads to irreversible damage, leading to graft loss, and including fibrosis or scarring. There are many variables that can increase a patient's risk for rejection, but the major one is going to be under immunosuppression or not optimizing a patient's immunosuppression regimen. So this is where maintenance immunosuppression strategies come into play. Different transplant centers may utilize different strategies. However, I will be focusing on the strategy that we use at our transplant center. The timing of maintenance immunosuppression starts immediately post-operatively. It can be as early as the night that they come out of the OR. The duration is going to be the life of the graft. And generally, we will use a multi-drug regimen strategy, so agents with different mechanisms of actions to prevent T cell activation. The three major classes of medications that we use are going to be our calcineurin inhibitors, our anti-proliferatives, as well as our corticosteroids. So we're going to begin with our calcineurin inhibitors. Within the calcineurin inhibitor class, there are two major groups. So these are Tacrolimus as well as Cyclosporine. There are slight differences in mechanism of action. However, as we can see in the picture to the right, we have our T cell, which is a main player in rejection pathway. So many of our immunosuppression agents will work on preventing this T cell activation. With calcineurin inhibitors, both Tacrolimus and Cyclosporine will form a complex with calcineurin in order to prevent the activation of nuclear factor of activated T cells. This will block interleukin-2 and other cytokine production and therefore inhibit T cell activation or proliferation. When looking at Tacrolimus, the major takeaway points in the differences between immediate release versus the extended release are the following. Immediate release comes in formulations, so capsules, granules for oral suspension, as well as ampules for IV administration. For oral route, it is usually given twice a day, ideally 12 hours apart, and we will counsel the patient on taking the medication with or without food consistently. That means that if they choose to take the medication with food, they should do it consistently every day in order to keep a consistent absorption of the drug. This is going to be important because we do monitor tacrolimus levels. And in the immediate release tacrolimus, we want to get a level 12 hours after the last dose, or basically right before their next dose. In the extended release version, the brand name is Envarsus, it only comes in tablets. If we want to switch a patient from immediate release version to the extended release version, we need to calculate 80% of the immediate release total daily dose. A key counseling point is to have the patient take extended release tablets on an empty stomach. It is only taken once a day. The patient is not to crush or chew the tablets. We want to obtain a 24-hour level after their last dose, and there is a leeway of obtaining the level within 21 to 27 hours after their dose. So what levels should we be targeting? Again, every center may have different targets. However, at our institution, we aim for a target level of 8 to 12 within the first 6 months of transplant, 5 to 10 within 7 to 12 months of transplant. And then after a year, we generally will try to keep the patients at a level of 5 to 8. The goal trough, as we notice, may decrease as time passes, and this is in part due to tolerance or graft acceptance as time passes. We do need to keep in mind that immunosuppression may be an art, and sometimes the levels may need to be adjusted depending on patient factors and what they need. So for example, if a patient is experiencing multiple episodes of infections or adverse effects, we may want to target a lower level sooner than what our protocol states. What are some factors to help us in deciding whether to prescribe immediate release versus the extended release version of tacrolimus? In general, this is also institution specific. However, at our institution, we will begin the patients on immediate release tacrolimus and then titrate to goal levels. However, there are patients who are considered rapid metabolizers and may metabolize tacrolimus quicker. Studies have found that 45 to 80% of African Americans may be rapid metabolizers compared to other ethnicities. The risk that rapid metabolizers may have is that they will require higher tacrolimus dosages, but still be at suboptimal exposure of the medication throughout the day because their body is metabolizing the drug too quickly. This will put them at an increased risk of rejection. These higher doses of tacrolimus may also cause a big spike of drug level in the body. So we can see that in the picture, the orange spike over there depicts a patient being put on high doses of tacrolimus. This can lead the patient to have an increased risk of side effects. So for patients who are placed on the extended release version, so we can see with the dark blue line in the picture, we see that they don't have the spike, and they also will maintain a good level throughout the day. So for our patients, we may consider switching them from immediate release to extended release if they are requiring higher doses of the tacrolimus. And I just have a quick knowledge check. So which of the following dose conversions is correct? A, Prograf 6 milligrams twice a day would equal Envarsus 8 milligrams daily. Prograf 5 milligrams twice a day will equal Envarsus 8 milligrams daily. We didn't touch upon CellCept yet, so we're just going to touch upon A or B. And the correct answer is B, because remember, when we are switching the patients over, it is going to be 80% of the total daily dose of the immediate release version. So for a patient on Prograf 5 milligrams twice a day, that's a total daily dose of 10 milligrams. So 80% of that is going to be 8 milligrams daily for the extended release version. Now we move on to our second group of medications in the calcineurin inhibitors. And this is cyclosporine. We don't use cyclosporine as often in our institution. However, it is still prescribed occasionally. The major takeaway point that I want to point out to everyone is that there is a non-modified version versus the modified version. So Sandimmune is non-modified, and then Neorol and Gengraph are going to be our modified versions, okay? In general, with the modified version, the drug is in a microemulsion formulation, which leads to better absorption, higher bioavailability, and more predictable pharmacokinetics. So they are not bioequivalent. If we want to switch a patient between the two different types of the cyclosporine, it is still a 1-to-1 dose conversion. However, just keep in mind that we will need to increase monitoring in order to ensure that when we switch the patients, they still maintain the same levels. With this medication, it is still also given 12 hours consistently with or without food. We do also monitor trough levels, and the trough level goals do decrease as time goes on. So we've been talking about therapeutic drug monitoring, and I want to touch upon this briefly. Why do we do therapeutic drug monitoring, especially for the calcineurin inhibitors? So the goals of therapeutic drug monitoring is to maintain efficacy while preventing side effects. Calcineurin inhibitors have a narrow therapeutic index, meaning that at too high levels, patients may experience side effects, but at too low levels, they may have risk for rejection. There is large inter and intra-patient variability with this medication. And remember, there are a high number of drug interactions, which we will touch upon in a few slides. So when do we want to monitor the levels more frequently? We will want to do this when there is a new start of the medication, after any dose adjustments, changes in formulation, or changes in administration route. If there's any change in graft function or signs of rejection, because we want to check if maybe the levels are too low. Signs and symptoms of toxicity to check if the levels may be too high. Any addition of medications that may interact, or if there's any changes in a patient's underlying conditions, such as, for example, with severe diarrhea, a patient's Tacrolimus level may increase drastically. So let's touch upon side effects. Drug interactions. So both Tacrolimus and cyclosporine are cytochrome P450 or 3A4 inhibitors. So then the drug interactions I want to focus on are going to be the 3A4 inhibitors or 3A4 inducers. So with 3A4 inhibitors, these are going to cause an increase in calcineurin inhibitor concentration. So it's going to cause an increase in levels. Major drugs are going to be your protease inhibitors, such as ritonavir, which this is commonly seen in HIV regimen, azole antifungals, your macrolide antibiotics, the non-dihydropyridine calcium channel blockers, as well as with amiodarone or dronedarone. Grapefruit is not a drug. However, it will also cause an increase in calcineurin inhibitors as well. So in general, we counsel patients to avoid grapefruit. For 3A4 inducers, these are going to decrease calcineurin inhibitor concentration. And most common agents are going to be your rifampin, rifabutin, your anticonvulsant agents, such as phenytoin, the carbamazepines, as well as St. John's wort, which is a common over-the-counter medication. With P-glycoprotein, cyclosporine may increase concentration of other P-glycoprotein agents, substrates, so such as digoxin, colchicine, statins, and as well as sirolimus and everolimus. So we just want to be aware that if we're going to be using cyclosporine with any of these agents, that we will need to monitor both agents carefully. We've been talking a lot about adverse drug reactions. And one major concern that we have as a team is to ensure that the patients experience as little side effects as possible. And it is important for us to know what these side effects are. So common side effects that are seen more so with tacrolimus are going to be our neurotoxicity side effects, so such as headaches, seizures. The tremors are going to be a common one. Altered motor function, for example. Tacrolimus can also cause GI distress as well as hyperglycemia. Cyclosporine, on the other hand, may have higher incidences of hypertension and higher cholesterol. Other side effects that may be seen with both drugs are going to be your hepatotoxicity, electrolyte imbalances, abnormal hematology lab values, as well as nephrotoxicity, which we will talk about in a few slides because this is of utmost importance since most of our patients are kidney transplant recipients. There are also cosmetic side effects that I want to touch upon because these are also very important since they can increase the barrier for adherence or compliance with patients. So for Tacrolimus, we may see alopecia, which is hair loss, the hyperuricemia, QT prolongation, and cyclosporine. Some cosmetic side effects are going to be gingival hyperplasia, so gum disease. So it's very important to counsel patients on having routine follow-up with their dentists, as well as hirsutism, which is hair growth. So this is a common issue more so with women that may cause a barrier to compliance. In terms of CNI nephrotoxicity, the most common mechanism is due to the vasoconstriction of afferent arterioles. The symptom is going to be similar to that of rejection. So sometimes it's difficult to tell whether or not a patient is experiencing calcineurin inhibitor nephrotoxicity or rejection. There may be a gradual rise in serum creatinine. Patients may have fever, some hypertension, but they will not. Management of CNI nephrotoxicity are generally to reduce exposure of the medication. So you want to reduce the dose of this medication, avoid other nephrotoxins. You may want to delay administration of calcineurin inhibitors immediately post-op. We can opt to switch to another immunosuppressant agent, or there's also other methods such as CNI withdrawal or CNI minimization, where we add on another agent to the tacrolimus. I have another knowledge check here. So patient XY is a 42-year-old male, status post-kidney transplant 1 year ago. He is currently on maintenance immunosuppression with tacrolimus, mycophenolate, and prednisone. His tacrolimus trough levels are currently at goal. He presents to his primary care physician with mild COVID symptoms, and his doctor would like to start Paxlovid. So this is nirmatrelvir and ritonavir. What are considerations that need to be made with this patient's tacrolimus? Do we want to increase therapeutic drug monitoring frequency? Do we want to avoid use of Paxlovid if close monitoring is not feasible? Will we consider holding tacrolimus during Paxlovid treatment? Or no changes need to be made? Or A, B, and C are all correct? Good, excellent. So yeah, A, B, C is all correct. Thank you. So ritonavir, one of the components of Paxlovid, remember, has a very severe drug interaction with tacrolimus. So this is actually kind of a real patient case where the patient was started on Paxlovid and not routinely monitored, and his tacrolimus levels spiked up to over 40, and he experienced some acute kidney injury. So in the case of this, we do want to increase monitoring. We may want to consider holding the tacrolimus during this time. And if the patient cannot be monitored, we may want to consider an alternative agent and not use the Paxlovid at this time. Our second class of immunosuppressive agents are the antiproliferatives. So this is going to be our mycophenolate and azathioprine. And in general, both medications work on inhibiting cell cycle of the T cell to, again, stop the proliferation of T cells. The major thing I want to point out is that with mycophenolate, there is CellCept, which is what we routinely use. And there's also Myfortic, which is a delayed release formulation. This delayed release formulation was made to help patients experiencing GI side effects. However, studies have not shown consistent alleviation of GI side effects when the patients are switched to Myfortic. Okay, but one key takeaway point I want to make is that if we want to switch the patients between CellCept to Myfortic, it's not a one-to-one conversion. So CellCept 1,000 milligrams will be Myfortic 720 milligrams. Both medications are going to be taken twice daily, and we want to counsel the patient on taking the medication with food because this will help with the GI side effects. A unique thing about the metabolism of this drug is that it is not as straightforward. So there is something called enterohepatic recirculation. And basically, mycophenolate is a prodrug, and it gets hydrolyzed and activated to the active metabolite. So we're going to call it MPA, mycophenolic acid. And then it is then further metabolized to mycophenolic acid glucuronide, which is an inactive metabolite. And this is where it gets interesting because this inactive metabolite can be either excreted in the bile or excreted in the urine. If it is excreted in the urine, then it's gone. However, if it is excreted into the bile, it actually recirculates back into the active metabolite, so the MPA form. And this results in secondary peaks of the active drug being present in the body 6 to 12 hours after the drug is given. And I want to touch upon this because it does play a role in the drug interactions and considerations. So major drug interactions with mycophenolate are those that either decrease the absorption of this drug or that interferes with the enterohepatic circulation that we just talked about. So drugs that may commonly decrease the absorption of this drug are going to be our antacids or proton pump inhibitors. So with the antacids, we want to just counsel patients to take 2 hours after mycophenolate. But with proton pump inhibitors, the clinical significance is unknown. So we just kind of want to monitor the patients for any alterations in efficacy. If the medications such as with cyclosporine, antimicrobials, sevelamer, bile acid sequestrants that may interfere with enterohepatic recirculation, we also want to monitor for alterations in efficacy. And with sevelamer, we want to give 2 hours after the mycophenolate dose. And with our bile acid sequestrants, we basically just don't want to use it because this will basically prevent the enterohepatic recirculation from occurring. Common side effects of mycophenolate are going to be myelosuppression. So signs and symptoms are going to be neutropenia as well as leukopenia. So in general, we want to reduce or hold the dose of this drug and manage with our filgrastim as needed. With gastrointestinal side effects, so patients may experience nausea, vomiting, diarrhea. This is usually responsive to dose reduction or reducing the dose interval. So changing the drug instead of twice a day to 3 times a day instead, or 4 times a day. We can switch to delayed release formulation, so Myfortic. However, as I stated earlier, the studies had mixed results. And of course, we want to counsel the patients to take with food to help with these side effects. Another important thing about mycophenolate is the risk evaluation and mitigation strategies, so the REMS program. So in general, the risk of mycophenolate are, especially for women of reproductive age, so 15 to 49 years old, is that it can cause a higher risk of miscarriage within the first 3 months, as well as birth defects, okay? So for women of childbearing age, we want to counsel them. We have to counsel the patients on acceptable birth control methods. Counseling materials are available on the website that I listed at the bottom of the birth control options. And we need to have the patient sign a acknowledgement form that information was given to them on prevention of pregnancy while on this medication. However, if a patient is considered family planning and the graft is stable, we may consider switching the patient over to azathioprine. The patient will still need to be on effective contraceptive for up to 6 weeks after taking the last dose of mycophenolate. And for women who have mycophenolate exposed pregnancies, there is a website here that we may want to consider reporting it to so that the patients can be monitored and get help as needed. We'll touch briefly upon azathioprine. So this agent is not commonly used anymore. However, again, if a female is family planning, we may want to switch the patient over to this agent instead. We have to get the thiopurine methyltransferase or TPMT levels prior to starting because patients with a lack of TPMT function can have increased risk of life-threatening myelosuppression, toxicities, as well as increased overly immunosuppression. And then the third and final knowledge check. So Casey is a 59-year-old male post-op day 3 from deceased donor renal transplant. He received anti-thymocyte globulin and high-dose steroids for induction therapy and is now receiving steroid taper. Maintenance immunosuppression consists of tacrolimus, mycophenolate. He begins complaining of diarrhea and abdominal pain. Infection was ruled out as a cause for GI side effects. So it was not infection. So what is the best course of action to take to reduce the adverse effects that Casey is currently experiencing? Do we A, give loperamide until diarrhea resolves? B, the corticosteroids should be tapered more quickly over the next 3 days instead of 2 weeks. change the Tacrolimus to Envarsus, give Tacrolimus with food, or counsel the patients on giving the Mycophenolate with food. So yeah, so that's a major counseling point for patients experiencing GI side effects that we want to give the patients to have them take it with food, the Mycophenolate. Our third and final class of immunosuppressive agents is going to be our corticosteroids. So the mechanism of action of steroids is not quite fully understood. However, it is thought to block multiple cytokine activations. At high doses, it is thought to be directly toxic to T cells. And at lower doses, it decreases activation of T cells by inhibiting interleukin transcription. It does also have anti-inflammatory side effects. However, as we are well familiar, corticosteroids have many adverse drug reactions. So these include psychiatric, skin soft tissues, neurologic, cardiovascular, musculoskeletal, endocrine, immunologic, ophthalmic, and in young children, it can cause developmental delays. So here at Downstate, in order to help minimize some of these side effects in some of our patients, we have a maintenance steroid group and an early steroid withdrawal group. Okay. In general, the maintenance steroid group are going to be patients maintained on steroids because they have a higher rejection risk. And the early steroid withdrawal groups are generally off steroids by post-op day 5, unless in incidences of delayed graft function where steroids will be continued until resolution or up until 30 days. The rationale for this approach comes from a study conducted by Woodall and colleagues in 2008. So this is a prospective randomized double-blind placebo-controlled multi-center trial comparing early corticosteroid cessation, so within 7 days, or long-term low-dose corticosteroid therapy. So these patients are maintained on 5 milligrams daily. The population consists of 386 deceased and living donor adult kidney transplant recipients without delayed graft function. They received antibody induction, and maintenance immunosuppression consists of tacrolimus and mycophenolate mofetil. So this is very similar to our population in terms of immunosuppressive agent. And the results that they found was that between both groups, there was no difference in composite of death, graft loss, or moderate severe acute rejection. However, biopsy-confirmed acute rejection was higher in the steroid withdrawal group, but these are primarily mild or BAMF1A rejections that were primarily corticosteroid sensitive, so they were easily treatable. The incidences of antibody-treated rejection or more severe rejection was similar between the two groups. At the 5-year follow-up, there was no difference in renal function. Serum triglycerides and weights were improved in the steroid withdrawal group, and new onset diabetes after transplant was actually similar between the groups. However, fewer patients in the steroid withdrawal groups required insulin at the 5-year post-transplant mark. So in summary, we need to weigh the benefits and risks of immunosuppression very carefully and optimize patients as best as we can. Benefits of using immunosuppression, of course, include the prevention of rejection, improving graft function, and increasing a patient's quality of life. However, certain risks are also present. So these are malignancies, our infections, and toxicities. So it is a balancing act. I do want to touch briefly upon other agents that we use. So in particular, anti-infection prophylaxis. This will be talked about a little bit more in the case study that one of our other speakers are going to touch upon. However, infection complications are going to be most life-threatening complications of long-term immunosuppression. So this can occur if a patient is overly immunosuppressed. This can contribute to graft loss and decrease long-term survival, and it increases the risk for post-transplant malignancy. So we do give routine prophylaxis post-transplant. And the first step, if a patient gets an infection, is to consider reducing or holding immunosuppression. But there's a caveat to this because we do want to consider the patient's history and evaluate a patient's rejection risk and if they were at a higher rejection risk or if they had rejection in the past. So common infection prophylaxis agents are going to be those that prevent cytomegalovirus, pneumocystis pneumonia, or thrush. For cytomegalovirus, we use valganciclovir. This is usually 3 to 6 months prophylaxis. We do want to monitor for neutropenia and GI side effects. For pneumocystis pneumonia, our main common agents are going to be the sulfamethoxazole trimethoprim, and this is usually given up to 1 year post-transplant. We do want to monitor for hyperkalemia, myelosuppression, as well as a rash. And however, this medication should not be given in patients with sulfa allergies. So in this case, the second line agent that we may want to start a patient on is going to be dapsone. However, dapsone does require a G6PD testing prior to administering. Our third line agent is going to be atovaquone. However, there is a higher risk for non-compliance on atovaquone just due to taste. It only comes in a liquid form, and patients generally do not like the texture and the taste of it. For thrush, we can use nystatin or clotrimazole. At our center, we will be using clotrimazole. We start early after transplant, and we continue for at least 1 to 3 months. There are some concerns with clotrimazole because technically it is an antifungal. And so there is concern that it can cause calcineurin inhibitor levels. However, studies have found conflicting results. And in general, this is not a major source of concern because clotrimazole is not really ingested. So there is no systemic absorption of this agent. And then one last thing I want to touch on, and it's a very common question asked by patients as well as their provider outside of the transplant team, is over-the-counter medications. In the interest of time, I'm not going to go over all of it. I have included a link where you can go ahead and find the PDF of a compilation of all the over-the-counter medications that a patient can take. But in general, it's going to look like this. So a patient's going to find their problem. So for example, if they're experiencing cough, they can go down to the cough section and they can see that it's safe for them to take dextromethorphan. Common brand names are going to be Robitussin or Delsym, for example. One thing I do want to touch upon is for diarrhea. We do want to counsel patients to check in with their provider first because diarrhea can be a result of medication side effects. However, it can also be due to infections, and we do not want patients taking loperamide and keeping that in their system. If there are any over-the-counter medications not on this list, please have the patient consult the transplant physicians prior to starting any new medication. And with that, I just want to thank everyone for attending.
Thank you, Jane, for that in-depth, very informative, and I would say mind-blowing presentation. Thank you.